So imagine for a second that you are managing the water supply for an entire city.
Oh, that sounds stressful already.
Right. I mean, you've got millions of people, countless buildings, and they're all relying on this constant pressurized flow of water just to, function on a daily basis.
Yeah, the whole grid depends on that pressure.
Exactly. But now, imagine a massive main break happens right in the center of town, just water gushing out into the street. The pressure in the entire grid starts to absolutely plummet. What do you even do?
I mean, do you just crank up the pressure at the pumping station, like force more water through?
Or do you shut off the valves to the suburbs to save the downtown hospitals? And, how long can the system hold on before the whole grid just completely collapses?
It's basically the ultimate crisis management scenario. And it is exactly what is happening inside your own body when you start losing your most precious resource, which is, fluid and blood volume.
Yeah. And that brings us to today's mission for this deep dive.
Yeah.
We are decoding the really high-stakes physiology of what happens when the human body springs a leak.
It is a wild topic.
It really is. Our sources today are these foundational medical pathophysiology notes covering hypovolemia and hemorrhage. And we are going to explore how century-old battlefield observations, a tragic plane crash in a Nebraska cornfield, and modern clinical trials have completely flipped our medical understanding of how to save a life when blood volume drops. Okay, let's unpack this. Because before we can even talk about how the body reacts to losing blood, we have to look at the definitions.
Right, the definition.
Yeah, and apparently the medical definitions themselves are a bit of a trap.
Oh, they definitely are. The terminology trips people up constantly. Like in casual conversation or even in some hospital hallways, you might hear the terms hemorrhage and hypovolemia used interchangeably.
Like they mean the exact same thing.
Exactly. But physiologically, they're entirely different concepts. So hemorrhage is a physical mechanism. It's the actual loss of blood from the vascular system, like a cut artery or a bleeding ulcer.
Okay, so it's the physical bleeding.
Yeah. Hypovolemia, on the other hand, is a state of being. It simply means an abnormally low volume of circulating blood plasma in the body.
Right, so hemorrhage is the event, and hypovolemia is the condition. Which means, if I'm getting this right, you can become severely hypovolemic without bleeding a single drop.
That is the crucial distinction, yes. You can lose massive amounts of volume through severe vomiting, terrible diarrhea, extensive burns, or even fluids shifting out of the blood vessels and into the tissues.
Oh, wow.
Yeah, and clinicians group all of these together under hypovolemic shock, but only once the volume deficit gets so bad that it actually compromises blood flow to the organs.
Okay, I want to pause on another distinction from the notes because I know I used to conflate these all the time. Hypervolemia is not the same thing as dehydration.
Not at all, and that's a super common misconception. Dehydration is specifically the loss of free water relative to solutes, which raises your blood osmolality.
So like the water-to-salt ratio gets messed up.
Exactly. Think of a hiker lost in the desert. As they sweat and exhale moisture, they are losing water. So their blood is literally getting thicker and saltier.
Oh, yeah.
Yeah, but hypovolemia is the loss of isotonic fluid, meaning the water and the solutes are lost together.
Ah.
So if someone is actively bleeding, the fluid they have left in their veins is still chemically balanced, There is just not enough of it to go around.
That makes total sense.
They often overlap in the real world, sure, but functionally, they are completely different physiological problems and they require totally different interventions.
But the craziest part of this whole definitional trap to me is the concept of effective circulating volume.
Oh, yeah. That's a big one.
So a patient with advanced heart failure or edema can be swollen with excess fluid, like physically puffed up, but functionally they are hypovolemic. It's like having $1 million in a frozen bank account. The money's technically there, but your debit card keeps getting declined where it actually counts.
What's fascinating here is how that exact tension changes everything depending on the specialist looking at the patient. Classic physiology, used to define hypovolemia by an absolute measure.
Like a set number of liters.
Right. Like if you have less than your expected 5 liters of total blood, you are hypovolemic, period. But modern critical care focuses entirely on what the body's internal sensors actually feel.
So it's about the flow, not just the tank.
Exactly. Let's take a patient with advanced cirrhosis of the liver, for example. Because their liver isn't making enough proteins to keep fluid inside the blood vessels, that fluid leaks out.
It just escapes the pipes.
Yeah, and it pools in their abdominal cavity, which is a process called third spacing.
So their total body water is incredibly high. I mean, they are heavy with fluid.
Yes, but their arterial circulation, the actual pipes delivering pressurized blood to the organs, is underfilled. The debit card is declining, like in your analogy. So a nephrologist or a trauma surgeon looks at that patient and sees someone who is, paradoxically, volume overloaded, but effectively hypovolemic. The organs are literally starved for flow, even though the body is drowning in fluid.
That is just wild to think about. Okay, so once that effective volume drops, whether from a bleeding wound or fluid leaking into the abdomen,
Mm-hmm.
how does the body realize its bank account is empty? I mean, it doesn't just passively accept this drop in pressure, right?
Oh, no, it mounts an incredibly aggressive defense. And to understand how, you kind of have to look at the physics of the heart, specifically the Frank Starling mechanism.
I remember reading about this. It's from like over a century ago, right?
Yeah, discovered over a century ago. It basically describes how heart muscle fibers respond to stretching. The heart depends on preload, which is the volume of blood returning to the chambers right before each beat.
Okay, so I'm picturing a rubber band here. If you pull it back just a little bit, it kind of weakly snaps forward. But if you stretch it back nice and tight, it snaps with a ton of force.
That is the exact mechanical principle at work. Inside the heart wall, there are these overlapping protein filaments, actin and myosin.
Right.
When a healthy amount of blood fills the heart, it stretches those muscle fibers to their optimal overlapping distance. That allows them to grip each other tightly and contract with maximum force.
Okay, but if you are bleeding,
If you're bleeding, less blood returns to the heart. So the preload drops, the muscle fibers aren't stretched enough, the rubber band isn't pulled back, and the heart pumps less blood out. That is a drop in stroke volume.
and if stroke volume drops, the pressure in the whole system just plummets.
Which would be instantly fatal if the body didn't have hidden alarms to prevent it.
The baroreceptors.
Yes, the baroreceptors. They are these specialized stretch sensors located in the carotid sinus in your neck and the aortic arch right above your heart. They are constantly, and I mean constantly, feeling the physical tension of your arterial walls.
So when blood volume drops, the walls cave in slightly.
Right, the physical stretch decreases.
And so the baroreceptors just go quiet.
And the brainstem interprets that silence as a catastrophic threat. It instantly unleashes the sympathetic nervous system.
Full panic.
Complete panic mode. It dumps norepinephrine, increasing the heart rate and violently constricting the peripheral blood vessels. The body actively shunts blood away from the skin, the gut, the skeletal muscles, basically rerouting every drop of available flow to protect the brain and the heart.
Which perfectly explains why someone in shock looks so pale and feels cold to the touch. The body has literally shut off the suburbs to keep the downtown hospitals running.
It's triage at a cellular level, but the nervous system is just the first responder. The body also calls in the heavy artillery, which is the endocrine system.
Oh, the kidneys.
Exactly. The kidneys act as the body's internal water meter. They have a specialized cluster of cells that literally measure the flow of blood coming in. When that flow slows down to a trickle, the kidneys release an enzyme called renin.
This is that RAS cascade from the notes, right?
Yes, the renin-angiotensin-aldosterone system. Renin triggers a chain reaction that produces angiotensin II, which is one of the most powerful vasoconstrictors in the human body.
So it forces the blood vessels to clamp down even tighter.
Way tighter. It also triggers the release of aldosterone, which tells the kidneys to stop making urine and hoard every single molecule of sodium and water they can find.
So no fluid is escaping.
Right. And simultaneously, your pituitary gland starts dumping vasopressin to conserve free water. It is a massive, highly coordinated, multi-organ survival response.
And this brings us to how doctors actually classify this response in real time, because they need a way to measure how deep into the crisis a patient actually is.
Yeah, you need a system.
Right. And the sources tell this incredibly intense story about where the modern trauma classification system actually comes from. It was back in 1976, an orthopedic surgeon named James Steiner was piloting his family in a private plane when they crashed into a Nebraska cornfield.
It was a horrific tragedy. His wife was killed instantly, and several of his children sustained severe injuries.
Yeah. And when he finally managed to flag down health and get his family to a small rural hospital, he found the emergency care to be just completely chaotic. It was just ad hoc improvisation.
Well, it's typical back then.
The doctors were doing their best, sure, but there was no system. Steiner realized that trauma care couldn't just rely on whatever a physician happened to think of in the heat of the moment. It needed a universal, teachable protocol?
So he partnered with colleagues at the Lincoln Medical Education Foundation to develop a structured course.
Mm-hmm.
And by 1980, the American College of Surgeons adopted it as Advanced Trauma Life Support, or ATLS.
ATLS, right.
The ATLS classification of hemorrhagic shock divides blood loss into 4 classes, and it really remains the most influential framework in the world for reasoning about trauma.
So I was looking at that ATLS classification in the notes, and here's where it gets really interesting and honestly a bit terrifying to me. Class I hemorrhage means you've lost up to 15% of your blood volume. For an average adult, that is about 750 milliliters. That is a full unit of blood, like the exact amount you would give if you sat down at a blood drive. And yet, if you put that person on a monitor, their vital signs are completely normal. The blood pressure is normal. The heart rate is normal.
Which is exactly why relying on systolic blood pressure to tell you a patient hasn't bled much is one of the most common and dangerous mistakes in medicine.
Really?
Oh yeah. By the time that top blood pressure number actually drops, you are usually entering class 3 shock. You have lost 30 to 40% of your blood volume. You're down almost 2 liters.
Because those compensatory mechanisms we just talked about, the baroreceptors, the massive RAAS cascade, the clamped blood vessels, they are working so hard to mask the disaster.
Hiding it.
Yeah, they're squeezing the pipes to keep the pressure up right up until the moment they physically can't anymore, and then the patient just crashes.
Yeah.
So if blood pressure is basically a dangerous liar in early trauma, what is the truth? Like, what should a doctor actually be looking for?
You look at the pulse pressure, which is the gap between the systolic and diastolic numbers.
Yeah, top and bottom nerve.
Exactly. In early hemorrhage, the systolic pressure might stay normal because the heart is beating harder, but the diastolic pressure starts to rise because all those peripheral blood vessels are clamping down, creating immense resistance in the system.
So the bottom number goes up.
Right. So the gap between the 2 numbers shrinks. A narrowing pulse pressure is the earliest measurable clue that the body is desperately trying to hide a volume drop.
That is so subtle. I mean, if the pressure changes from 120 over 80 to like 115 over 95, the top number still looks totally fine, but the gap went from 40 down to 20. The pipes are clamping down.
Precisely.
And the notes mention another trap clinicians fall into regarding heart rate, right? Because the textbook says as you lose blood, your heart rate goes up. But that isn't universally true.
Far from it. If you have an elderly patient with poor cardiac reserve, their heart physically might not be able to beat faster. Or if you have an elite athlete, their resting vagal tone is so strong it basically overrides the panic signal. Or consider the millions of people taking beta blocker medications for hypertension. Those drugs chemically block the heart from speeding up.
So you could be actively bleeding to death with a completely normal or even a slow heart rate.
You absolutely could.
That's terrifying. So we have a body throwing everything it has into masking a leak. For decades, if a doctor saw someone bleeding and their pressure finally started to drop, the medical instinct must have been to just help the body out, right? To hook up an IV and pump them full of fluids to refill the pipes. Why was that instinct so deadly?
To understand why, we kind of have to look back to World War I and a Harvard physiologist named Walter Bradford Cannon. He spent the war in France studying what he called traumatic shock in wounded soldiers.
Okay.
Cannon noticed this terrifying pattern in the medical tents. Soldiers would arrive severely wounded, but their bodies had managed to form fragile clots, so they seemed stable.
And then the medics would intervene.
Right. The medics would rapidly pump them full of intravenous fluid before a surgeon could get in there and actually tie off the bleeding vessel. Cannon observed that raising their blood pressure artificially just blew out the fragile blood clot they had formed.
You just blasted it away.
Yep, restarting catastrophic bleeding, they would rapidly decompensate and die.
It is exactly like trying to patch a leaky garden hose while simultaneously cranking up the water spigot to max pressure. You are just going to blow the patch right off into the yard.
If we connect this to the bigger picture, the medical community completely ignored Cannon's lesson for the better part of a century.
Are you serious?
Yeah. During the Vietnam War, the prevailing medical doctrine was aggressive, large-volume fluid resuscitation. They pumped wounded soldiers full of crystalloid fluids like normal saline to artificially keep their blood pressure up.
But saline isn't blood. I mean, it doesn't carry oxygen, and it definitely doesn't clot.
It is essentially salt water. And they pumped so much of it into these young soldiers that it caused a phenomenon informally known as Da Nang Lung.
Da Nang Lung. What is that?
It was a form of acute respiratory distress syndrome, or ARDS. By overloading the body with saline, they were diluting whatever clotting factors the soldiers had left, and the excess fluid was literally leaking out of the capillaries and flooding their lungs.
Oh my God.
They survived the bleeding only to drown in their own beds.
That is a staggering medical failure. It took until, what, 1994 for Cannon to really be vindicated?
Oh.
With that Houston penetrating trauma trial.
Yeah, led by trauma surgeon William Bickle. They ran a trial on patients in Houston with penetrating torso trauma, so gunshots and stab wounds.
Right.
They compared giving immediate aggressive IV fluids in the ambulance to a group where they withheld fluids entirely until the patient was actually in the operating room with a surgeon.
And what happened?
The delayed group, the ones who got less fluid, had significantly better survival rates.
Because popping the clot is real.
It is entirely real. That trial helped establish the modern standard of care known as permissive hypotension. In actively bleeding trauma patients, we now deliberately tolerate a lower than normal blood pressure.
So you don't want it perfectly normal.
No, we want the pressure just high enough to keep the brain and heart alive, but low enough to protect the clot until we can surgically stop the bleeding.
Okay, so we've stopped blasting patients with saline because it blows out the clot mechanically with pressure. But the sources reveal a much darker chemical reason where replacing lost blood with salt water is a terrible idea. And it revolves around something called the trauma triad of death, or the lethal triad.
The lethal triad consists of 3 interlocking conditions: hypothermia, acidosis, and coagulopathy. And once this triad begins, it forms a vicious, self-reinforcing death spiral.
Wait, okay, I get why losing blood makes you cold. You are losing warm fluid and you are exposed to the elements. But why does being cold stop your blood from clotting? Aren't temperature regulation and clotting like 2 completely different systems?
They are, but they are chemically linked.
Yep.
Your body's clotting cascade relies on dozens of specific enzymes and proteins to form a stable scab. Those proteins are highly complex, 3-dimensional structures. They are evolved to function perfectly at exactly 98.6 degrees Fahrenheit. When your blood temperature drops, the physical shape of those enzymes actually distorts. They literally cannot fit together to form a clot.
Oh wow, so hypothermia directly causes coagulopathy, the inability to clot.
Exactly.
But where does the acidosis come in?
That happens because your organs are starving. Since you've lost so much red blood, your tissues aren't getting enough oxygen. To survive, your cells are forced to switch to anaerobic metabolism.
Working without oxygen.
Right. Think of it like a car engine running out of clean oil. The engine will still run for a little while, but it starts grinding and producing thick, toxic black smoke.
And in the human body, that smoke is lactic acid.
Exactly. As the cells churn out lactic acid, your blood pH plummets. It becomes highly acidic. And just like cold temperatures, a highly acidic environment further destroys the shape and function of your clotting enzymes.
So because you can't clot, you continue to bleed. And because you are bleeding more, you lose more heat and more oxygen, which makes you even colder and even more acidic, which means your enzymes break down even further. You are just chemically sabotaging your own survival.
Which is exactly why trauma surgeons finally realized that giving bleeding patients packed red blood cells and bags of cold room temperature saline was just fueling the triad.
It was making it worse.
Way worse. In 2015, a landmark study called the PRO-EPR trial, led by John Holcomb, proved this out using data learned from combat surgeons in Iraq. They tested a 1-to-1-to-1 transfusion ratio.
Meaning 1 unit of plasma, 1 unit of platelets, and 1 unit of red blood cells.
Yes. They completely stopped trying to replace blood with saline and isolated red cells. They started replacing blood with components that actually recreate whole blood.
Oh, that makes sense.
By giving the platelets and the plasma right from the start, they gave the patient back the actual clotting factors they were losing, fighting back against the lethal triad before the death spiral could take hold.
So what does this all mean? I mean, for decades, we treated hemorrhage as just a plumbing problem, like fill the pipes with fluid to keep the pressure up, without realizing we were chemically and mechanically destroying the patient's ability to clot.
We were treating the monitor, not the patient. And this raises an important question. How quickly should medical dogmas change in the face of new, undeniable battlefield data? Because the fluid debate wasn't the only massive reversal we saw from recent conflicts in Iraq and Afghanistan. Look at the tourniquet.
Well, the tourniquet reversal is wild to me. When I took a basic first aid class years ago, the instructor basically told us, never use a tourniquet unless you are fully prepared to amputate that person's limb. It was taught as the ultimate destructive last resort.
That was standard teaching for the late 20th century. First responders and military medics were actively discouraged from using them. The fear was that completely cutting off arterial blood flow would cause irreversible ischemic tissue death, basically guaranteeing an amputation. But then military trauma researcher John Craw analyzed massive amounts of casualty data from the mid-2000s.
And the old dogma was completely backwards.
Entirely backwards. The data proved that early pre-hospital tourniquet application dramatically improved survival for severe limb hemorrhage,
And the amputation rate.
negligible compared to the lives saved. The reality is, the time it takes to get someone to a surgical facility is usually far, far shorter than the ischemic time required to actually cause irreversible muscle and nerve death. The fear of amputation was literally letting people bleed to death.
This intense trauma physiology, plane crashes, war zones, gunshot wounds in Houston, it can feel a bit disconnected from daily life. But the sources make it explicitly clear that these exact same mechanisms dictate everyday medicine.
Hemorrhage is still a leading cause of preventable trauma death globally. That's why the lessons from John Craw's military tourniquet research directly birthed the Public Stop the Bleed campaign.
Which is why you now see those brightly colored bleeding control kits sitting right next to the AEDs in airports, schools, and malls.
Exactly. We are finally treating hemorrhage control with the same public urgency we've historically given to CPR.
And beyond trauma, this explains so much about routine medical emergencies. The notes point out that postpartum hemorrhage remains a massive driver of maternal mortality. Routine gastrointestinal bleeds show up in local emergency rooms every single day.
Yeah, it's incredibly common.
Even non-bleeding hypovolemia, like a marathon runner collapsing in the heat, or severe dehydration from food poisoning. You might never see a combat zone, but understanding this physiology explains why a terrible stomach bug leaves you feeling so utterly exhausted and cold.
Right.
It's those exact same evolutionary alarm bells going off inside you, fighting to keep your brain and heart perfused by squeezing your vessels and spiking your heart rate.
It is all the exact same underlying physiology, just operating on a different timeline. And time is always the enemy. In the 1960s, a pioneering surgeon named R. Adams Cowley popularized the concept of the golden hour.
Golden hour, right.
It is that critical early window after a severe injury where medical intervention has the greatest chance of reversing the shock state before the lethal triad permanently sets in. That single concept still dictates how we design ambulance routes and fund emergency medical systems today.
So let's bring this all together. We started this deep dive talking about a city losing its water pressure. We have seen that volume is functional, that a frozen bank account of fluid doesn't help your starving organs. We learned that normal blood pressure is a late-stage liar and that the true early alarm is a narrowing pulse pressure.
We saw how decades of blindly filling the pipes with saline actually popped the clot and worsened bleeding, basically validating Walter Bradford Cannon's theories a full century after World War I.
And we explored how the lethal triad of cold, acid, and failed enzymes forced a total revolution in trauma care, bringing back whole blood resuscitation and putting tourniquets back into the hands of bystanders.
It's been a massive shift.
It really has. Knowing how our body defends its circulation is genuinely empowering. It gives you the context to question old assumptions, to understand why medical guidelines evolve, and maybe even to feel confident opening one of those Stop the Bleed kits if the worst ever happens.
Absolutely.
But there is one final piece of this puzzle that the sources hint at, and it is something for you to mull over. We've learned today that our body's compensatory mechanisms, the intense vasoconstriction, the RAAS cascade, the aggressive shunting of blood away from the gut and kidneys to save the brain, all of this evolved to survive acute, short-term trauma, like an animal attack, a sudden, brief wound.
Right, a temporary crisis.
But what happens when modern ICU medicine intervenes? What happens when we keep a patient hovering in this intense, hyperconstricted state of shock for days or even weeks on life support? Could the body's own heroic life-saving defense systems eventually become the very thing that starves and destroys its own organs? Something to think about the next time you feel your pulse quicken, because when the city's water main breaks, shutting off the valves to the suburbs might save downtown for an hour, but eventually the whole system has to face the drought. Thanks for joining us on this deep dive.